You're listening to In Network, Nordic's podcast series where we explore healthcare and technology with experts from around the globe.
Hello and welcome to the In Network podcast feature, Designing for Health. I'm Nordic's Chief Medical Officer, Dr. Craig Joseph. I recently sat down with Dr. Graham Walker, emergency room physician and co-founder of MDCalc. We discussed Dr. Walker's medical background, what drives him to make continuous improvements within healthcare, and how he co-created a clinical decision support company. We also talk about hospital rounds for clinician welfare, his experiences on an EHR steering committee, and whether it's possible to overcommunicate with physicians. Hint, it's not. Let's plug in. Graham Walker, welcome to the pod. How are you, sir?
Hey, it's so good to be here. I am wonderful. Thanks for having me.
Where do we find you today?
You find me in my lovely office, wallpapered by me and my husband. We did not kill each other. We're both alive and well. We wallpapered my lovely office. I'm about 2 blocks from Golden Gate Park here in San Francisco, California.
San Francisco. And are those plants native Californian plants that I'm seeing?
You know, he's the green thumb. I don't even water these things. He is kind enough to water them and care for them.
All right, fair enough. You're pleading ignorance. Here's one thing you cannot plead ignorance about: how you got to where you are now. I always like to kind of start with, hey, were you a young child and thinking, boy, I'd like to go to medical school, practice emergency medicine, and also have a technology wing to my career, start a couple companies, do all of that? Was that like something that you were thinking in nursery school?
Yeah, Craig, this was my 40-year plan. When I was 4, I manifested this and I just decided this is where I want my career to go. And then I just made it happen. I am that dedicated and focused and have that much foresight to know where my career would take me.
Excellent. Well, I like early starters like you, and you're the kind of person that we want on this podcast series. So
I was gifted and talented in elementary school. So
oh my God, it's getting deep in here. I thought I was the king, but you have just dethroned me. All right. Yeah. Boom. That's awesome. Well, so let me ask you this: when you were going to medical school, so you decided you were going to go to medical school. What kind of doctor did you want to be?
You know, I think emergency was always like in the short list, partially because of the show ER. I mean, definitely, like I was in high school when that was having its heyday. So that was always like on the list somewhere. And then, I think it's easier to know which specialties you don't want to do than the ones you do. And so once I finally did my ER rotation, I was like, oh yeah, these are my people. Like, dry wit, sarcastic, hardworking, a little bit of ADHD, get bored of a patient after more than 2 hours,
Yeah, no, it's great. Obviously there's an age difference because I thought you were going to go down the road of emergency from like Squad 51.
Oh yeah, no, I do know that that exists as a show, but I can't say I've ever seen an episode.
All right, that is disappointing, and we'll count against you as we calculate your score at the end of the show. So then you went and did an emergency medicine residency. Where did you train?
So I trained at St. Luke's Roosevelt. It's technically now Mount Sinai West and Mount Sinai Morningside Heights. It really rolls off the tongue there. But I will forever call it SLR, St. Luke's Roosevelt, in Manhattan, in New York City, on the west side. And incredible place to train, incredible group of attendings and nurses and colleagues and lifelong, friends now.
And did you have any kind of tech training or? And I asked to foreshadow because clearly you've started at least a couple of companies.
Ventures? Yeah.
Yes.
Yeah. No, I certainly attribute a lot of this to my dad. He's a psychiatrist, but also a computer nerd guy. I mean, we would go to CompUSA and get the latest Pentium processor, a 486, and I was so excited. We had I would play, computer games after I had installed like the 12 floppy disks to like get one game to load. I grew up learning from my dad, MS-DOS, how to show a file directory and open word processor files, and then Windows 3.1. And then really the internet really started, the information superhighway started when I was in high school. So I had time to teach myself some HTML and JavaScript and taught myself a little bit more in college. But, there were no college classes that taught the web at all. You had to take C or C++. And I was like, I'm not doing that. So I kind of used online tutorials and taught myself more web stuff. And then that's just, that's been where my sweet spot has always been, kind of on web development, web technologies. So no formal training, but certainly grew up around computers my whole life and still spend way too much time on computers today.
Well, that's fair. And I think as part of the computing public, we appreciate the time that you've spent on computers. And
shout out Don Walker. Thanks, Dad.
And I'm sure he's listening. He's a big fan. He's told us. So how are you from California? How did you go from New York to the other side of the country?
I'm from Kansas. I'm a Midwesterner from Kansas City, from the burbs. The burbs of Kansas City, Missouri. I live on the Kansas side. So I'm a Kansan. Went to Chicago for undergrad and then Stanford for med school. And then always had a fascination with New York. I thought, oh, perfect. 3 years in New York. Can decide if I want to stay there longer. Got drawn back out to California. Did a fellowship out here back at Stanford again. And then have been practicing here in San Francisco ever since. So finished fellowship in 2012. So yeah, it's 14 years now.
Okay. And you've been at KP the entire time.
Yeah.
Yeah. Okay.
Yeah.
And so you're a practicing emergency medicine physician. Most people kind of find that as a full-time job. Yet
Yep.
you and I think one colleague put together something called MDCalc.
Yeah.
And so how did that come about? And what is this MDCalc that people are talking about?
Yeah. Emergency medicine is a full-time job. I do find ER doctors tend to be some of the more entrepreneurial groups of folks. I think part of it is like the shift work thing. Part of it is the challenges of just our whole shift is just dealing with people who are having like the worst day of their lives. So we see all the problems in the system very like in our face. So yeah, in med school, 2005, was getting asked questions on Ranson's criteria, which is like a ancient score from the 1970s about pancreatitis, and asked, if I knew the criteria. And I was like, of course not. Why would I memorize these 12 esoteric criteria? And when there's a computer, like 2 feet away, and realized that there was not a place where all this stuff was, written down, or it wasn't a website that had all this. A bunch of different sites had a few different scores, but nobody had everything. So I decided, I'll just build this thing, because this clearly is a problem that needs solving. That it tends to be a common theme with my brain, is like, I see inefficiency, I see a problem, and then I want to solve it. So I would just go home from the hospital every night and just code, and then come back the next day. And then I think like 2 weeks into my rotation, I showed it to some like the interns, and they were like, sorry, what did you do? What did you build? And so I figured that was a good validation, a good thumbs up. And so then started thinking, okay, how many scores can I find? And I would go through remember those little pocket books with like 4-point font that we carry in our white coats?
Yeah.
Yeah. So I would just skim those and try to find scores. And they were often in like printed in little tables, so they were a little bit easier to find. It was like this, various criteria for cardiology, and the metabolic acidosis, Winter's formula to correct that, all that stuff. And then right after residency, my co-resident, Joe Haboosh, shout out Joe, my co-resident, was a year ahead of me in residency. He's an MD and an MBA, extremely brilliant and savvy business mind and emergency physician, importantly. He approached me and said, "Hey, I think what you've built with MDCalc is really valuable and it's really cool what you've done. What would you think if we teamed up? If I joined you, um, and we went from you just running everything to like, hey, we could build a business around this." And I said, "Oh, I never, clearly I'm not the savvy business mind here. I was, I had Google AdWords on the site and it was paying my cell phone bill, my gym membership. And I thought, what else do I need in the world?" Um, and that's resident, that's resident mindset right there. And Joe said, "No, I think it really could be a true business. I think it could really help even more people. We could grow it." And I said, "Oh, okay, sure, let's try it." I never really thought of it as a business. I just thought of it as like a thing that I'd built. And so certainly, with all to Joe's credit, Joe has figured out how to turn it into a sustainable business. And yeah, we are we're used, I think millions of times a day. Maybe it's millions of times a week, but I think it's close to millions of times a day. Physicians all around the world. We have, I think, over 800, maybe 900 scores on the site. And the idea is, if a doctor has a question about a particular patient and how they should manage them, we probably have a score that might help them take care of their patient with an evidence-based kind of research tool. So we review the research ourselves, make sure it kind of meets our standard, and then we put it up on MDCalc on the website, on our free apps. It's all free, and then people use it, and it hopefully helps them take better care of patients. We're used, we think, by about 2/3 or about 70% of U.S. physicians every month. So we're in a lot of doctors' pockets, and hopefully helping a lot of doctors with their patients, which is what drives me. That's what excites me, is like, oh my God, just it's so cool to see how much good this thing has done in the world, is the way I look at it.
So, but what I think is most important is you never answered the question, what are those Ranson criteria?
Yeah, I would, it's something about calcium, but it's like calcium 48 hours later, because, that used to be how we would manage pancreatitis. We would just put you in a hospital and check your calcium level 2 days later to see if like the pancreas had like eaten up your calcium,
Yeah. No, that's good. And also, I think our audience will want to know, what did the attending physician who was asking you questions, how did he or she respond to your answer of, no, of course not. Why would I memorize that? There's a computer right over there.
Now that tone and response is something today's Graham Walker would respond. But I think the medical student Graham Walker was a little bit more politically savvy enough to not really respond in that sarcastic tone. But it was one of the chief residents, who I think is now an interventional cardiologist at Stanford. Hi, Monica. Yeah, I think maybe she can take some credit there.
She was okay. She did not destroy you.
I was not made to feel less than.
Okay.
For not knowing Dr. Ranson's criteria.
Okay. All right. Luckily for you, it wasn't me, because you would have had a different outcome for sure.
Well, my pediatrics rotation. Now let's talk about some hazing.
We pediatricians are known for that.
Yeah, I know.
So, and my understanding is that MDCalc, that company, which again is kind of leveraged by almost 3/4 of physicians on a regular basis, that's not enough for you, and so you've got another. I know, because your ambition knows no bounds. You've got another company that is not officially out there, but you're teasing it around, called Off Call.
Yeah, we're teasing it to a select group of physicians, and hopefully having a public launch, a public kickoff in sometime later this fall. So in about a month or so, maybe right around the time this podcast drops. And it's a tool to try to improve the wealth and the well-being of physicians. Again, back to a problem that I'm seeing that like gets under my skin and I can't let go of. I'm just seeing a lot of physicians, Craig, who want to leave the bedside, who want to leave medicine, who I don't even know that burnout or moral injury is the right term necessarily anymore, but I'm just seeing so many physicians who are just kind of tired and fed up and don't want to do it anymore, and are hearing from other colleagues that, like, you could do something else, that you could do a side job, that there are other avenues for doctors. And that's just honestly for in in full, like, this might sound hokey, but like, for the health of our profession and of healthcare, that really bothers me. It really scares me that, like, every day people are just looking for a way out, or like maybe I'll go down on hours, or I'll stop doing XYZ. And so, yeah, we're building a platform to collect information about what makes a good job, what makes a bad job in terms of like a clinical job, right? It's not just the pay, but it's how many patients you're expected to see per hour, and do you have administrative support, or is everything a hassle to try to make change? You know, all that stuff, plus some content around what I'm kind of calling periclinical stuff. Like, it's not directly, stuff that you have questions about seeing a patient, but the stuff that's related to the stuff about seeing a patient, the meta stuff, and then some kind of social community tools to try to help with some of the I think connection that we've lost. We, like medicine, has lost during COVID. The bring back like a digital physicians lounge, try to get people to connect, whether it's over clinical stuff or it's like just finding ways to network and get to know other people who are interested in similar stuff, or like reconnect with your friends from residency. I mean, there's so many reasons that I think physicians would love to reconnect with each other. I think medicine's just gotten more lonely than it used to be. We're all so busy. We don't have nearly as much time for those kind of water cooler ish type conversations where you end up like collaborating with somebody you didn't think you were going to collaborate with, or getting to know somebody that you thought you had nothing in common with, or finding friendships or ways to deliver better patient care, all that stuff. So,
Well, I for one will be signing up and looking forward to all the fun conversation. And I'm particularly interested in how you design this, right? Like, how are you facilitating these conversations? And
yeah,
yeah, go ahead. How? Yeah, just give us the answer. Is it?
Well, yeah, it's all figured out.
Oh, good.
And we're done. Yeah, we launched yesterday and we figured it out today. It's all good. Yeah, it is going to be an interesting challenge to get. I think physicians typically we typically bucket ourselves by specialty, and like, I'm talking to another ER doctor, I immediately trust them, like them, whatever. But it's like, a pediatrician, or a cardiologist, I don't know if I can trust them or if I like them. So I think that is going to be one of the bigger challenges for us, is moving this idea, getting people to buy into this idea of we're stronger together. More transparency and more information for all of us is better. And it's, that it is going to be a change, but I think it's a necessary change, that we start to work together more and collaborate, because the current state of affairs, I don't think, is working very well. So yeah, I want to change it and try to improve it.
Yeah, I'm kind of fascinated by how I think we don't realize it till we start talking it through. But the job description is pretty unhelpful. To say, should I go to this health system or should I go to that health system, doesn't really matter. You can't decide based on, without talking to someone, like, hey, am I supposed to handle all the incoming patient portal messages, or someone taking most of those from me? And just tiny little things like that. It's almost never what's happening in the exam room, at least on the outpatient side, right? It's the things outside, and those are hard to, if you don't ask that question and then have that available in a discrete way for me to, like, yeah, if there's no good clinical support, I'm not even looking at this healthcare system. And then that makes it better for everyone, because that healthcare system certainly quickly learns like, oh,
bingo.
We're going to have to invest in more medical assistance, or yes, I have someone, but they just seem to forward all of the messages right to me. So,
and this is the exact thing that I love, Craig, is every time I talk to a physician about it and just kind of start the conversation going, just like you did, they literally complete the sentence for me. Like, I think people really get it, that how this thing hopefully is going to work, and that there is going to be benefit. Again, if we agree to we agree, or we choose to use the thing. So yeah, I'm hopeful and excited.
It's great. I think a lot of us I spent most of my time in the clinic. I'm as a pediatrician. That's where I was, but we didn't have hospitalists. I'm very, very old, Graham. We really didn't have hospitalists. And so one of my partners or I had to go to the hospital every single day to see our patients. And as we're seeing newborn babies, I'm seeing colleagues from other offices and all of that's now stopped. Some of it because of the pandemic and things changed, and others because we have hospitalists now. And certainly efficiency has helped. Like, that's great. I wasted a lot of time driving. Sometimes I go to 3 hospitals in one morning. Just because that's the way it was. And so I go to 3 hospitals to see 5 patients.
And your note was like 3 lines.
From a financial perspective, that was not a good decision. But yeah, it's changed now, and maybe the efficiency's up, but the humanity's down, and it's no good. No bueno. So let's talk about what you're doing now outside of your family of companies. So we mentioned that you work at Kaiser Permanente, and that you have some outside of emergency medicine, some other clinical responsibilities. So what are some of the other things that you do tech wise, at least?
Sure. So I've been on our EHR steering committee. So we use Epic. We call it KP Health Connect because we like to have our own lingo for everything in our organization. So it's called KP Health Connect. And so I sit on our core team, which is essentially our kind of governance and steering committee for emergency medicine and for urgent care. And it's a great group. It's a meeting that I look forward to every week, because the people in the meeting are all super fun. And I mean, you would love and probably know a lot of these people. It's the people that like care deeply about the nerdy informatics stuff, about the challenges of like building a new order set that has good usability and is not going to confuse people, but it does not have so much level of detail that people are just going to refuse to even open the thing or look at it at all. And everybody's really driven to improve patient care. That is always at the center of everything. So it's nice to be in a group that's so focused on, hey, how can we do this better? Like, that's literally the focus of everything, which is great. And it's such a diverse group of physicians and nurses and pharmacists and informaticists from around our region. I think we probably have maybe 60% of specialties, maybe 70% of specialties represented. So you get to hear from, well, how is this going to affect the hospitalist or the ER doctor or interventional radiology or the outpatient spine surgeon or the plastic surgeon? You hear about how this one little thing is going to, oh, well, if we do that, it's going to really screw things up for X group of people. And how do we, it's kind of like politics. It's like, how do you manage all of those constituents and everything?
And so is it true that you don't just care about what's going on with emergency medicine to the detriment of every other specialty? Is that not accurate?
If I was in charge, certainly the only thing we would do is emergency medicine. But unfortunately, we do have to take some consideration into the other fields of medicine, even though they're clearly not nearly as important as the ER.
Inferior is the word you're looking for. One of the things that you brought up when we were preparing for this episode was in-person rounding. And now rounding is something completely foreign to you as an emergency medicine doctor. We do these things. When I say we, I mean real physicians. We would go and see patients in their hospital rooms up on the floors, not in this. I know. It's confusing to someone like you. We would round and just go all around the hospital to see these various patients. They weren't conveniently located in a small room, probably what 20 by 20 is the size of your emergency room, I would imagine.
It is one room. We pack them in like sardines.
Yeah. So this was something that was introduced to you where you got to do in-person rounding, but you weren't rounding for patient care. You were rounding to see how it was more clinician care, I would say, maybe. Tell us about this.
Yeah. So one of my roles that I just ended earlier this year, I was the assistant physician in chief for technology for my medical center. So that's kind of like a CMIO light to some degree. It's a mixture of tech operations, training, reporting outages and bugs, troubleshooting issues, educating clinicians. You can never over educate or communicate a change coming to anything in technology. And and we started this, 6 months before COVID, but one of the ideas we had were just it's kind of like this similar idea of like death by 1,000 paper cuts, all these little subtle annoyances that are too small to like quote unquote make an IT ticket for, or too insignificant for somebody to then follow up on the ticket if it didn't get fixed. And so you just deal with it, you do the workaround, but it's just a little thing that like is so annoying. And they often never get fixed because they're too low on the totem pole of priorities. And so our idea was, well, okay, let's just go to the Gemba, go to where the sausage is made, go to where the EHR is being used, and just walk around and see if we can help people with these little annoyances that we know exist. I mean, I know they exist because I see them in the ER or I see them anywhere I'm working. They exist everywhere, not just in healthcare, but everywhere in the world. But so we would just go to a department. It would be kind of myself on the physician leadership side, one of our IT technical leaders, a trainer, an Epic trainer who could answer just questions about how do I do XYZ more efficiently. It would be one of our site support people who can go into the back end of the EHR and make configuration changes. And we would let the manager and the chief of the department know, hey, we're going to show up on Tuesday afternoon. Is that an okay time for you? Sounds great. And then we would just there'd be like 6 of us who just show up and we say, hey, we're here. We're here from IT. How can we help you? And, sometimes it takes a little bit to get people to remember what's annoying about their stuff because either it's so ingrained or they don't do the workflow frequently enough. But several examples stuck out in my head. One was a medical assistant who gives all the vaccinations in, I think, our adult and family medicine department. And I think she's been doing it for like 15 or 20 years. And, there's all this paperwork because you have to give a little handout about the vaccine, a paper handout by law or whatever to the patient. Or maybe they have to sign something. I can't remember. And we just watched her working, just kind of, qualitative interviewing almost. And we saw she would multiple times a day, she was clicking a button and then she would just disappear for 30 seconds. We're like, where are you going? And she's like, oh, well, this thing that I print out for vaccines every day prints out across the hall. So I just have to, it's no big deal. I just have to do that. And I was like, wait, how many times a day do you do this? And he's like, oh, I don't know, 10 or 20. And so just thinking, and of course the solution is she didn't know, and we hadn't told her that we could remap that workstation to a printer that there was literally a printer right next to her. And again, it was just one of these small annoyances that she was like, oh, I guess that's how it works. That, there's not a way to get my computer to talk to the printer right next to me. I just have to do this 20 times a day. And so, we saved this woman thousands of steps a week for this silly workflow because it was just too low priority. And I think also she, like I said before, I don't think she was aware that it was fixable. Or maybe somebody told her it wasn't fixable. Or maybe it used to not be fixable. I mean, these are all possibilities. That's the challenge of the progress of technology, is getting down to, to a medical assistant and letting her know, hey, we've made these improvements and changes and fixes, but maybe they take a little bit of configuration to make happen. And I don't know that any large organization can really do that effectively. And so I think that's why the IT rounds was really successful, was we were able to like bypass all those layers of bureaucracy and get right to the end user and just say, hey, what can we fix? What's broken?
Yeah, I love that. And it's a great story because there's so many things in healthcare, well, probably in all kinds of different industries, but so many things. You go into any hospital or office and you see kind of horrible settings that are completely changeable, that either no one changed or no one asked about, or someone asked and it went into some help desk, death spiral, and disappeared. And the story I love to tell, it's actually in the book I co-wrote, is talking about my daughter, who I took to a university for headaches when she was a kid, and they were using Epic as well. And at that time, I actually worked for Epic, so I was watching the MA or nurse, whoever was rooming us, put her information in, and she went to the reason for a visit, which was 2 boxes. One was a drop-down box. She had to choose something, and the other was a free text box. And again, this is at a pediatric neurology clinic.
Probably sees headaches a lot.
I don't know. I'm not here to judge. Went to other, selected other, because there was no headache, of course. And then typed in the word headache. And I asked her that same question that you just made. I mean, I asked her the question. I already knew the answer. So do you see a lot of kids with headaches that here in the peds neurology clinic? And she said, well, yes, we do. And I said, but I don't see it on that drop-down list. And she says, no, it's not there. And I said, it could be there. She goes, oh, it could. I'm like, it could. Yeah. Did you ask anyone about it? And she said, no, I don't think we can now. She said, when we went live a year ago, there should be a piece of paper where we put things that were broken, but I don't even know how to tell someone now.
Or who would I tell?
Right. And so it's these little things. I had a similar story when I was the CMIO. I got much more credit and thanks from physicians when I fixed a documentation template that had a typo in it in the 3rd paragraph with the 2nd sentence, that they went and fixed every single time because they're anal retentive. As well they should be if they're physicians. And when I said, hey, how about that cardiology module?
Right.
That cost $5 million. And he's like, well, that's all right, but you really made my day when you fixed that typo. And that was not sarcasm. That was the truth. So it's these little things, and you don't discover them unless you're walking around. And even if you ask, like you said earlier, half the time no one even remembers, as this woman didn't.
And there's so many layers between that nurse and the decision maker who decides what the dropdown can include. That's the other challenge, is, say she reports it, it becomes probably a ticket somewhere, but then how does the ticket person know how to get it to that decision maker who might not be in IT? They may be a clinician, they may be a nurse informaticist, but maybe they're not like in the same org structure, or it goes into the ticket black hole somewhere.
Yeah. And I tell you another thing there. I think having folks kind of understand at least even a little about the technology that they use every day, the major tool, is we don't ask why enough, right? Why is that printer not working next to me? And why do I have to choose something from a list anyway if I have just a free text box? What is the benefit of that? And I happen to know, since I worked at that company at the time, I said, oh, and I said, to the nurse, I said, if there was a selection for headache and you chose it, we could put smart sets or order sets and documentation templates. We could queue them up for you. They'd be ready there for you. You wouldn't have to go and choose them. And she said, "Oh, that would be helpful." So, yeah. Yes, it would. Yes, it would.
Craig, when I was right before medical school, I would make people little websites, like little small business websites, in my free time for just from extra cash, because I was working for a nonprofit and wasn't making much money. And I did one for, I think, like a roofing company or something like that. And the owner was a very nice guy. I can't even remember how I met him, but he would call me incessantly and say the website's down. And I would, and I was very retentive as well. I was like, no, I'm sure it's up. And sure enough, I would type in the website name and it was up, it was working, everything's working. And he kept telling me, no, the website's, it's back down again. And I would be losing my mind. And this was 2002. So it's not like there weren't cell phones. It wasn't hard to take screenshots, everything. I went to this guy's house and I was like, can you show me the website's down? Because the website's up for me. And so I'll never forget this. I watched this man who's, not a tech guy. That's not his job. I watched him open up Netscape or Internet Explorer 6 or whatever it was. And it would open to the Google homepage and he would type in the domain name into the Google search bar. And this was before we had one bar at the top of the browsers that would do search and address bar lookups. So he would type in whatever it was, chicago-roofing.com. I don't remember. He would type that in. And because I hadn't submitted it to Google, Google didn't know about it. And Google at the time didn't just also refer you and say, oh, you typed in a URL. Did you mean to just go to that URL and make it easy to click on it? And so that was such a life lesson of, oh, we are just speaking a different language. I'm technically right, but what the client is saying, I had to go to see exactly what he meant, because once he showed me, I immediately understood everything about it and I was able to solve it, right? I was able to say, okay, yeah, let me submit this site to Google. I got it submitted to Google, and a week later, what do you know? The site was never down again. So that was the other, get curious, not furious thing, where it's sometimes you just have to go see what the hell the person's talking about and have an open mind and not be increasingly annoyed, as I'm sure I'm able to get, especially with my lovely parents who I try to do tech support for. And, I think it's hard to not get frustrated with your parents and doing tech support for them.
I like that phrase, get curious, not furious. I'm going to have to remember that. One thing I wanted to just touch on a little bit in the time we have left is you had just said something. You said a few minutes ago, it's almost impossible to over-educate, I think, physicians or over-communicate with physicians. Can we dig a little deeper into that? What do you mean?
Let's dig. I can dig deeply on this one. I'll give you my opinion and my working theory. You cannot over communicate to a physician when it comes to a change to the EHR or a new way that you're going to be doing XYZ. Right? Maybe it's not a tech thing at all, but it's we have a new way that we're going to be doing paracentesis, or there's a new kit, or there's a new IV pump, or something, whatever it is. You cannot over communicate it because the number of times I have what I thought was over communicate something, hey, there's this big massive change. Epic introduced this thing called Storyboard. This was probably 4 or 5 years ago, and it was going to change dramatically what the EHR was going to look like when you opened up a chart. And so I sent emails, I did screen share videos, I I think I probably made a jingle or something like that. I mean, I really tried to communicate this. And we have a whole structure of technology leaders in each department who also their job is to help communicate out these big sweeping changes so that nobody gets confused on day one. And what do you know? I got like 3 emails from physicians, in all caps, angry. What did you do? Nobody told me this was coming. I can't, I can't order my my steroid cream, whatever it is. I can't find the patient's phone number, whatever. And so that lesson was just doctors are busy. They don't always check their email. They don't always attend the staff meeting where maybe this was discussed. They don't always attend the leadership meeting with the CEO where I've like even asked the CEO to, hey, just show this slide, just tell them, hey, ask Graham if you have questions, but just so they've seen it once, so it doesn't look totally shocking to them. And still, even then, and I was working with 600 physicians, so it's a lot, but it's not thousands. Even then, still multiple people. I've never seen this. What are you doing to me? So yeah, you cannot over communicate. It is literally impossible. And it's probably also just the innovation diffusion curve. Like some people are going to adopt storyboard immediately and totally get it, and other people maybe they have seen it, but they're just confused by it, or they're scared by it, or it, they've lost their muscle memory, and that's so critical to them getting through their day because they're not good with computers or whatever. So I get it, but yeah, that was the takeaway from from my work.
So despite all of your attempts to design multiple different modes and ways to get to them, there's still some you're never going to get to.
Yeah, and I think accepting that just comes with the territory, and that certainly, I think early on I maybe would have viewed that as a sign of failure, that I had done something wrong, and at some point you just accept, part of the diffusion curve, part of the change management is going to be, yeah, you'll probably get a few emails, so just be ready the day of to reply to a few emails, and that's also just part of the process. It's not a failure. It's just an expected part of change management too.
Sure. Yeah. I learned a lot from watching my cell phone change, right? There are apps that I thought are great, and I got them totally pegged and figured out. And then overnight, my button's been moved, and it really irritates me. Or there's this thing that used to be one click and now it's multiple, and I hate it. And if I had your phone number or your email address, I would have emailed you and complained about this, that my app, and it might be that's how I deal with off call and MDCalc, but we'll take that later. But then if you wait a couple weeks and someone says to you, hey, I know you were upset about that change in that app. Do you want to go back? You want us to make it go back to the way it used to be? Myself personally, almost everyone I know, they'd be like, what are you even talking about?
I think that is a key reflection, Craig. And it's something that I think, internally we at KP have tried to do a better job on, is reminding people of how far we've come. So there really, truly is value in just scribbling down a list of the 10 improvements or changes that we made in the past year. And it helps remind people like, oh God, remember when we had to carry pagers, or remember when we had to write triplicate prescription pads. And if you didn't have your pad, you had to go bother your neighbor and ask them to write some Norco, whatever it was. So I do think that's part of just the human condition. It's not even a doctor thing. It's just part of the human condition that we have the ability to forget. To some degree, forgetting is a blessing. But we are always going to be looking at the next annoyance we will never be fully satiated that like, oh, you got rid of pagers for me, that's enough. It's like, okay, well, no, we got rid of pagers, we switched to a secure texting app, but now we need these extra features for the secure texting app. That's just the human condition, I think. And again, it's not a failure. It's just how human brains work.
Well, Dr. Walker, we have come to the end of our time on this podcast episode.
What?
I know.
Say it ain't so.
Before we let you go, and I'm using the royal we, before we let you go, I like to always ask people at the end of our interviews, since we like to talk about healthcare and design, are there things in your life, is there one or two things that are so well designed that they bring you joy and happiness? Do you have one or two?
I do. I was talking with the Nerd MDs guys about this, Adam and Dale, but there's an app
called... I don't, wait, time out. We're not going to talk about the Nerd MD guys on this podcast.
Oh God. So, yeah. Bleep. Can we start over?
Yeah, no, the whole thing's done. The whole episode will now never see the light of day.
We'll do it live. Yeah.
All right. Yeah. No, all right. Keep going. We're going to let it go.
There's an app for Mac called Raycast. And it is, if you use a Mac or even Windows 11 now has this kind of searching tool as well. But right now, Raycast is just for Mac, but it's coming to Windows and to iOS. But the idea is super nerdy, but with just keyboard shortcuts, you can control everything about your computer. You can hit one keyboard shortcut to open up a certain website. You can hold another keyboard shortcut to connect to your Bluetooth headphones. Another can open up the dictionary app. Another can do complex automations and talk to AI. It has the ability to like launch applications, search your files, do all sorts of automations, and it's pristinely well optimized for like keyboard people like myself. So you can kind of like dance your fingers over the keyboard and get your whole configuration set up for working efficiently, right? So I could open a browser window and have it take up just the top left of the screen. And then I could open another browser window and have it open up a podcast app. And then another browser window could open up Spotify in my second screen. It's hyper configurable to a fault. And for people that like control over their computer like I do, it's an extremely well-designed app, and it's free also. I highly recommend it for everybody.
Awesome. Raycast. All right. And it is, it's only Apple right now, but at some point.
I think they just got like $30 million of funding to bring it to Windows and to iOS. So.
All right. And
big fan.
Regarding the controversy from a minute ago, I've been handed a piece of paper that now reminds me that Adam Carew has appeared on this podcast, and Dale Gold is scheduled to appear on this podcast. So I will have my comments stricken from the record.
Retract. Yeah.
Awesome. Well, thank you so much. It's been a great conversation. Really enjoyed having you. Greg. And I hope everyone checks out MDCalc and Off Call when it's available, and read your LinkedIn commentary because it's brilliant.
Thank you.
And if they ever have an emergency when in San Francisco, I hope they seek out your care.
Yeah. Just honestly, just stop by my house. I mean, I might not be working, but yeah, just
so do you
come
go
by.
You go to Golden Gate Bridge and you just scream Graham. Is that how that works?
Yeah, it's like a bat signal. Yeah.
you'll come, or you'll go in the other direction depending on what the need is. All right. Well, in all seriousness, thank you so much. Really appreciate it, and look forward to all the great things in your future.
Thank you. Thanks for having me, Craig.
Thanks for tuning in. We hope you enjoyed today's episode. For more on Dr. Walker, follow him on LinkedIn by searching for Graham Walker, MD. Check back for more episodes of Designing for Health wherever you listen to podcasts or on NordicGlobal.com. Till next time, we'll see you in network. If you enjoyed this episode, please leave us a 5-star rating and a review. This helps others find the podcast as well.